Welcome to the Prevea orthopedic presentation all about ACLs, how to prevent the injury and the treatment options available if there is an injury to the ACL. Let's welcome Dr. Scott Haskins as your presenter for today. Dr. Haskins.
Thanks, Chris. Hi, everybody. Thanks for tuning in tonight. My name is Scott Haskins, as Chris said, and I work for Prevea Orthopedics. Just a little bit about me before we get started. My location is mainly in Sheboygan. I also have satellite clinics in Manitowoc and Plymouth. I'm a general orthopedic surgeon, so I do complete relatively comprehensive care for things such as fractures, joint replacements, and pretty much all around orthopedics. My specialty is in sports medicine. So people often ask what sports medicine is. It does encompass a lot of different things for active people from all walks of life. I do focus a lot on the knee, things such as ACL injuries, like we'll talk about tonight, cartilage, meniscus, different arthritis procedures. The shoulder is also a very common joint that I see and work on. Also ankle, hip, elbow, and hand. For the sports medicine fellowship, I completed that in Minneapolis at Prevea Orthopedics. That's also associated with the University of Minnesota. Going back in my training, I did a residency at the University of Kansas at the Wichita site. I also did med school and undergraduate at University of Wisconsin, so Badger through and through. And I grew up in River Falls, Wisconsin, over on the western side of the state, and I'm happy to be over here. My family enjoys the area, and it's been going very well. Although I am located in Sheboygan, we do have orthopedic providers all over the state. So along eastern Wisconsin, up through Green Bay, and over in the Chippewa Valley. So if you are in one of those sites closer to those areas, there are lots of orthopedic providers for you to see. So tonight we'll be talking mainly about the ACL, the anterior cruciate ligament, and why it is important. We'll also talk about what happens if you do have an ACL, if that's torn. We'll talk about what can be done to prevent injury and what should be done if the ACL injury is suspected. So why are we talking about knees? It's definitely one of the more important joints in the body. It's one of the strongest and most mobile joints. It allows the lower leg to move with the thigh in coordination to allow you to do pretty much any activity. Movements at the knee joint are essential to all kinds of different activities, as you know, walking, running, standing, pretty much anything you want to do. So having a healthy knee that you can use and function well is important to basically any physical activity that you need to complete. So the anterior cruciate ligament is in the central aspect of the knee. It's called a cruciate ligament because it forms a cross with the posterior cruciate ligament. These two ligaments keep the knee from sliding back and forth across each other. It provides stability in that direction. It also provides rotational stability. So rotational stability is very important for activities that involve changing direction, pivoting, cutting. So it is very important, especially for younger and active people, for those activities that involve pivoting, cutting, changing the direction, and sidestepping. A lot of the activities you see pictured here, football, soccer, even simple activities such as golf. The ACL injury is actually one of the more prevalent injuries in active people. There are approximately 250,000 ACL tears per year in the United States. And the surgery itself generally costs at least $20,000 to the healthcare system plus rehabilitation. So that equals up to a $5 billion annual cost to the healthcare system. It also has a large cost for lost work, lost activity, lost return to sport, as it can take 6 to 12 months to really return to your desired activity level. And there can even be a high rate of re-injury upon return, whether that be the same knee, the opposite knee, or a different part of the extremity. So ACL injuries can occur in several different ways. The most common is actually through non-contact injury mechanism. So this involves something that happens where someone is running, changing direction, and they are not contacted. So this is most common. It can happen in any sports, but common in soccer, basketball, skiing. The remaining 20% are associated with contact injuries, more common in football, hockey. There can be contact injuries in basketball and other sports for sure. The non-contact injury generally occurs with landing, rapidly stopping, cutting, or changing direction. It can also happen with a hyperextension injury, whereas the contact injury generally occurs with a blow to the side of the knee, coming from the lateral side in general, just as that's the more common side to get hit from, such as a tackle in football. ACL tear symptoms, we have listed here. We'll talk about some of them, but oftentimes it can not be readily apparent that something has happened. Someone will just feel a small shift in the knee. Oftentimes people with an injury can get up and keep running and keep participating, but it just feels like something's not right or the knee is just not quite stable. Other times there can be a larger pop or snap. The pain is generally deep, kind of non-specific, not to a specific location in the knee. Most of the time you do get swelling the same day or overnight that night. In fact, that's one of the main signs that you do have an ACL tear. That can also happen with meniscus tears and some other injuries, but same day swelling is present in over 70% of these injuries. Another symptom can be just instability with walking, especially with side to side or change in direction. Initial treatment is relatively simple. Stopping the activity that you're doing, resting, icing, compressing with an ACE bandage or a knee sleeve, elevating. These are just things to reduce the initial swelling that can really cause a lot of significant pain. You also want to protect weight bearing with crutches, meaning take some of the weight off of the knee. This is especially important if you're limping. If you do suspect you have an ACL, or if a member of your team is suspected of having an ACL, the appropriate thing is to kind of work on the treatment that we just talked about and then see your primary care or orthopedic provider for a simple physical exam to look at the knee. We may schedule an X-ray at that same time and an MRI, which can actually give us the full detail of the ACL. The initial physical exam can be somewhat challenging because if you don't catch the knee right away before that swelling occurs, people tend to have a lot of guarding and stiffness and spasm of the knee, so it can be somewhat difficult to actually tell if there's an ACL. Some injuries are more unstable and it's relatively obvious. So after the physical exam, we would schedule that MRI, such as the one pictured here, that would allow us to see if there is a tear and also allow us to see any associated injuries within the knee. There are some situations where you may want to seek more urgent care, either in an urgent care or emergency room setting. This would be if the knee is locked, if you can't put the knee through a range of motion or a very limited range of motion, if unable to bear any weight through the leg. So usually an ACL will allow you to kind of limp around a little bit with pain, but able to do it. If you're unable to bear any weight, there may be a more serious injury such as a fracture or a dislocation of the knee. If you do have numbness or tingling to the lower leg or foot, this may indicate a nerve injury, which may be better to seek care earlier, or if unable to move the foot for the same reason. So when we do confirm an ACL tear, there are some different options for treatment, although surgery will be the predominant treatment for full thickness ACL tears. Not everyone does need surgery. We can treat some cases with simple, reduction in pain and swelling, and then subsequent bracing and physical therapy. Candidates for this are people with a partial tear with no instability symptoms. Even sometimes partial tears may need surgery, but if you have a partial tear with no instability symptoms and are able to return, then you don't need to have surgery. For low demand patients who don't participate in physical activity or have a job that requires that, and then minimal symptoms after the initial recovery. The goal for non-operative treatment is to regain motion, get back to the normal walking mechanics, work on hamstring strength, core strengthening to really stabilize the knee, and then gradual return to activity. Even this can take a few months to return to full activity. The negative side of this is that it can lead to increased cartilage and meniscus damage due to kind of these micro instability events or these small shifts and changes of the knee with activity. It can result in loss of meniscus function, difficulty with activity such as cutting, change in direction, and heavy lifting. But some people do tolerate it fairly well. For surgical treatment, the main candidates for this generally tend to be younger people, but can be anyone really up through 60s, even 70s in some situations. Older age is not necessarily a contraindication. If someone is active and participating in these activities and needs stability, they can be a surgical candidate. Most of our patients are under 40 just because they tend to be more active and involved in these sports. Patients participating in work, sports, home activities that require higher level knee function, heavy lifting, pivoting, changing direction. There are several different kinds of methods for ACL reconstruction that we're not really going to get into tonight, but you can learn more about that on our website, actually. And if you do have to see someone for this, they'll explain to you all the different treatment options. Sometimes we are able to repair an ACL, but this would be a rare situation, although some of the technology is evolving to maybe allow that more. There are different grafts that we use. So we reconstruct the new ACL ligament. So you can use your own tendon, which is called an autograft. You can use patella tendon, hamstring, or quadriceps. And then there are options to use allograft tendon, which is cadaver tissue. And then the recovery is a gradual increase in activity and strengthening of the knee, and does generally take 9 to 12 months for a full participation in sports and getting back to jobs that require heavier levels of activity and lifting. So now we're going to move on to the portion about prevention of ACL injuries. This is a table from the listed study here that we're not going to go over every single box here, but this does illustrate the amount of things that can contribute to risk for an ACL injury. And we'll go over some of them in the following slides, but there are a lot of different factors, some intrinsic to the athlete or active person, and some extrinsic, say to the field, weather conditions, skill level, and sometimes even just luck and having an opponent in a certain spot or a certain bounce of the ball and things like that. So there are a lot of things that go into the risk for ACL injuries. And we'll talk about ways that we can prevent some of them from happening and reduce the risk of the ACL injury. So I talked about the intrinsic anatomy part. So there are definitely biomechanical factors that put some people at risk more than others. And, unfortunately, we don't always identify these risks when people start participating in sports. One of the main ones is female versus male, with just some different anatomical and biomechanical features. So females tend to have wider pelvises, which give a higher Q angle, which is this angle that is shown in relation to the femur and the lower leg. And that results in a valgus knock-knee landing position, which puts the ACL at more stress. Females also have some hormonal factors. So ACL injury has been tied to certain times in the cycle. So hormonal factors even play a role. Increased hamstring flexibility and foot pronation increase risk. And then there are neuromuscular factors. So the way that the nerves interact with the muscles that are different between the two, female versus male. Other intrinsic factors, there can be a genetic predisposition. So there's still a lot of research going into this, but some increased risk in families can occur with certain collagen defects. So there are genes in the DNA that code and make the collagen for the ACL. Having defects in the strength of that collagen can result in increased risk of ACL injury. I don't believe there is any screening for that at this time, nor necessarily should there be, but perhaps sometime in the future that may be an option. Different sport participation will increase the risk of an ACL injury. The highest tend to be football, soccer, lacrosse, gymnastics, basketball, skiing, but certainly an ACL injury can happen in most sports. Skill level can be a factor. So things like jumping, skiing techniques, all kinds of different techniques around the sport. Being more confident and skillful in the sport will also allow for more confident motions. So that can play a factor. There can be psychological factors. This one is big, especially for people who are coming back from any type of injury, whether it's ACL or other. They can have a fear of injury, and that may cause hesitancy of motion or some awkward motions or landing positions. This is called kinesiophobia, and can be fairly common. And then the other is physical fitness. So there is an increased risk of injury, both of the ACL and lots of other musculoskeletal injuries with increased muscle fatigue and muscle weakness. So increased fitness can help go through longer periods of time in the game or the sport. And this is one part that we talk about recovery for athletes and being prepared for the fitness level of the game. So not being prepared for that can increase the risk of ACL injury. Extrinsic factors that I had mentioned earlier. So the surface type, they've done a lot of studies on this. So the increased risk comes with increased surface friction. So we moved a lot to artificial floors. There was a very strong push for that, I believe, in the 90s and early 2000s, but they found that there was a 2.5 times higher risk because of the higher friction compared to the wood surface. Certain turf surfaces have caused this, and I think as the technology evolves there, they're trying to avoid that as much as possible. For shoe wear, more cleats in the shoe, on the bottom of the shoe, or larger cleats providing more traction can lead to increased risk of ACL injury. For footwear, that can be important. You want to have the proper fit, want to be sure that they're not worn. There have been instances of ACL injuries when a shoe blows out and the foot goes through while the shoe stays in the same spot and causes a twisting injury. Weather, the dry conditions increase the risk. So there's actually less ACL injuries in wet and rainy conditions, which might be a little counterintuitive because you picture people slipping and falling, but that allows for the foot to kind of move across the grass a little bit easier with less friction, which does provide a little bit safer, at least for ACL injuries. And then unanticipated situations can occur. So bumps, uneven surfaces in different sports, misjudgment in a jump or avoiding an opponent. So all these can factor into that ACL injury. One thing we think about for ACL injuries is the possibility of bracing for preventing injury. Unfortunately, there's not been any scientific evidence to show effectiveness in preventing that tear. It's not recommended for regular use. Even after surgery, it hasn't shown to prevent re-tears or provide stability. Some people do allow to choose to wear it after surgery in certain sports. A prominent one would be like skiing or football, where you might have a contact there on the field. One spot that it has been shown to help is to prevent MCL injuries in contact sports. That's why you see the linemen all lined up in the NFL with the braces on both of their legs. It's not necessarily for the ACL, but it does prevent injury to those collateral ligaments. It may be considered for non-operative treatment. So like this brace that's shown here has a stop in the front of the tibia on the lower leg there. So that provides a stop against that anterior translation. It's generally not strong enough if you have a mechanism for an ACL injury, but it can help provide some stability in non-operative treatment. So for a prevention program, the main goal is obviously to decrease the number of ACL tears. So some goals for a program would be to improve neuromuscular control and train proper movement patterns. We also want to gain biomechanical efficiency and accuracy of movement. So this can be trained, the body can be trained to do these things through training, drills, practice, and being in these game situations. We also want to enhance the dynamic strength and muscle endurance of the trunk, hip, and knee. So we'll talk about the factors here in a prevention program. So things that can improve and that are important factors to a prevention program, first of all, is age. So they've done studies in these programs and found that fewer injuries occur when the when the program is started at a younger age compared to older. So for instance, if we start a prevention program in a soccer club, if it started when the athletes are 10 years old instead of 14 years old, they do see less injuries throughout that participation period. For a frequency of a prevention program, want to do it about 2 to 3 times per week for at least 8 weeks to build up the different factors. And then you do need to maintain the program throughout the competitive season to avoid deconditioning, which can happen relatively quickly, even as quickly as 2 weeks. So for sports like basketball, which may have a break like over the holiday season, you want to make sure that the athletes are still participating in these exercises to maintain the strength and neuromuscular conditioning. For timing, you definitely want to implement in the preseason or even out of the season before everything gets started. If you start this in the season, that's probably going to be too late, not allowing that full 2 months to really build up. We also want it to be easy and low cost. Identify the at-risk population. So these have been found to be most effective when targeted to female athletes. Not that it's not effective in males, but it can provide the biggest bang for the buck in the female athlete population. Also, some people elect to screen with the drop vertical test, where you have the athletes drop from a height and see how they land, and people with poor mechanics would benefit the most from the program to improve those mechanics. You also want to have feedback through this program. So monitoring with coaches, athletic trainers, conditioning coaches with feedback going through. And then exercise variability is good, meaning not subjecting the body to the same exercises nonstop, having a variability in those. So there are a few different components here that we'll talk about: education, dynamic warm-up, strengthening, neuromuscular training, and plyometrics. So education is important. It can be provided by many different people: educated coaches, athletic trainers, strength and conditioning, teammates even. And the important thing is proper jumping mechanics, especially like in the sports we see here: volleyball, basketball, gymnastics, landing things. It's important to be educated on how you're supposed to do these things. Also, proper sport-specific mechanics. Mainly how to jump, how to land. even in football, how to run, how to tackle. And then even rules can be important for ACL prevention. As funny as that seems, just knowing the rules, being confident in motions, being confident in what you're doing on the court or on the field can be important in reducing injuries. So I've talked about the jumping technique a lot here, just to kind of run through some things that can be thought about. When you jump and land, you want to land on the balls of the feet with the knees flexed, initially at about 20 degrees and then bending down to about 40 degrees. Just cueing people to land softly has been shown to decrease force at the ACL up to 3 times. You want to keep your chest over the knees, avoid excessive movement of the knee upon landing. So you want to kind of stick that knee in a spot. You don't want to go too far forward or inward. And you want to keep the knee over the middle of the foot, keeping the hips straight without turning out or in, and then equal weight on the right and left foot. The next component is the dynamic warm-up, and this has been more and more popular throughout the years. In traditional athletics, we focused a lot on static stretching, but now I think most people have gone to these dynamic warm-ups. Increases the core temperature, heart rate, blood flow to the muscles. Lots of different examples can be used. So forward, backward jog, cone agility drills, high knees, butt kicks, and then dynamic stretches as well. And there are hundreds of different versions of these that can be used. Neuromuscular training. This is the ability to optimize muscle firing patterns. So you do specific exercises, motions that can improve the ability of this to occur. So this also increases the dynamic joint stability, improves movement patterns. Some examples, such as the one seen here, proprioception training, balance, wobble boards, single leg stability, jump training. Again, there's lots of different options for these that can be found either in prevention guides or online, both with videos and manuals and pictures. So lots of different things that you can choose from. For a program, you just include a few of them to be completed. The next is plyometrics. So plyometrics is exerting the muscle's maximum force in short time intervals to increase power. So this involves jumping, landing, and ballistic powerful movements. Examples include squat jump, lateral jump, power skipping, box jump, alternated leg bounding. So again, lots of different examples, but the combination of those 3 components put together all help to provide stability at the knee, especially for dynamic motion. And then strengthening as well. Alone, strengthening is not effective in preventing ACL injuries, but it's definitely a crucial part to the prevention program. Focus in general on the hamstring. So a strong hamstring actually keeps that knee back in the joint and prevents from moving forward when activated. And then core muscle training, hips, gluteal muscles, all provide stability of the leg and improve landing, jumping mechanics. So now that we've talked about the components of the program, can it be effective? And the answer is yes. There's been many different studies, and when completed appropriately, it can reduce the risk of ACL tear by as much as 50%. Studies have shown that those who did not participate are 1.5 to 2 times as likely to have a tear. So this is most effective in females in certain sports such as basketball and soccer, but it can be effective throughout all sports and even all walks of life. So there are several options for structured programs. We have one listed here, and I have it on the next page too. But there are different sports medicine websites and organizations that have some of these structured programs. So you can talk to your sports medicine doctor, athletic trainer, coaches. They all may have different sources to go to for these prevention programs. In ours, we have this binder. It's a 12-week course that you would use in the pre-season. It includes all these different components that we've talked about. And you can certainly feel free to call that number or talk to one of your Prevea providers to go ahead and purchase that. So that wraps up my presentation here. Certainly thank everybody for coming tonight, but we'll ask Chris if we have any questions from the crowd here tonight.
I do. Thank you, Dr. Haskins. We did have one individual submit a question. He was wondering if you would be able to elaborate on any advances in meniscus regeneration, if there's any information possibly looking at stem cells to replace cartilage or something along those lines.
Yeah, that's a good question. And it ties in pretty nicely to the ACL injuries, because associated with ACL injuries at a very high rate, actually, there can be meniscus injuries and cartilage injuries. And in the population that's getting the ACL injuries, these are things that generally can be repaired. And the technology, as he's saying there in the question, has improved significantly over time to allow us to successfully repair those structures. So the meniscus is that C-shaped pad. There's a medial and lateral meniscus. And with ACL injuries, there often is a peripheral tear along the ring of that meniscus. So that can be repaired. We have different suture devices that can repair that to get more healing in that site. We often elicit a bleeding response in that area too. As far as for stem cell regeneration of the meniscus itself, we don't really have an option for that, but the technology has improved in ways to allow us to increase the healing in those areas. We are working on technology to better be able to replace the meniscus as well. So either with meniscal transplants or synthetic padding there too. And that I'm sure will improve over time to limit the damage that's done with a meniscus tear. And then the cartilage is the smooth surface over the joint of the knee. And with that impact injury that occurs with an ACL, you can get cartilage injuries that can actually go all the way through the cartilage. So sometimes we can go ahead and repair that if it's big enough with screws, but sometimes it does leave a hole in the cartilage. And we have been able to progress to the point where we can use stem cells to repair that cartilage in this specific situation. There's lots of different options, but some involve taking a small biopsy at the time of the initial surgery and then growing your own cells in the lab and then coming back and placing those in the cartilage defect. So we can certainly kind of talk about the details of that. And I might actually come back for a talk in a couple months with some pictures of that I can show you. But technology has definitely advanced to allow us to repair the meniscus and cartilage along with the ACL and the ACL reconstruction.
Thank you for that answer, Dr. Haskins, and Tim, thank you for that question. If any of you do have other questions, feel free to unmute yourself while you do that and chime in and ask a question. While we wait for that, I do have a question of myself for Dr. Haskins. Dr. Haskins, I'm curious if there's a higher reoccurrence rate for individuals that suffer an ACL injury, whether, excuse me, in the same knee or in the opposite knee.
Yeah, there is a higher increased risk if you do tear your ACL. You're at a higher risk than, let's say, your teammate to have another ACL tear. It can be as high as like 5 to 15% in the contralateral side as you get back to full activity. And you can definitely have a re-tear of the ACL graft as well, although that actually tends to be a little bit lower than the contralateral knee. But relatively similar. But we really focus on trying to avoid that by kind of going through the things we talked about tonight through the rehabilitation process and making sure that athletes or people going back to their job are strong enough, have good enough neuromuscular control, and have the appropriate clearance before returning. So,
Thank you. Again, another kind of opportunity for anybody on the presentation tonight to ask questions. You can either unmute yourself or send a message through the chat. We'll kind of give that a few seconds. But while we wait for that, again, I want to thank everyone very much for attending this presentation. And we certainly hope that you found it valuable and helpful. If you should have any additional questions or are interested in making an appointment to see Dr. Haskins or any of our orthopedic providers, you can feel free to call Prevea Orthopedics at the numbers that are listed on your screen right there, and anyone we will certainly be able to assist. And seeing and hearing no other questions, that will bring an end to our presentation tonight. Thank you very much, Dr. Haskins, for this very informative presentation, and we thank all of you for joining us tonight. So finally, thank you and have a fantastic evening.